Hello, I'm Paul. I'm a member of the Vascular Access Service and one of the PIC nurses here at Dartmouth-Hitchcock. And we wanted to familiarize you with the various IV lines out there before this effort to get more of the floor nurses drawing central line labs from their patients. So I thought we'd take a look at things, what you're likely to encounter line-wise out there on the floor. If we start over here, on the upper left here are IVs that you're likely to encounter in the forearm. They're not usually used for blood draws, but occasionally they may work well for it. These are the short IVs. They're all about an inch long or a little less when we get to the smaller size. The 24 gauge is used in kids a lot, or in people that are just very, very difficult to access with very small vasculature. Then there's the 22 gauge, the 20, the 18, and the 16. 16s you're not likely to see on the floor. They're more ED related. But these others are very common, especially I would say our most common IV is probably in diameter is probably the 22 gauge. You can run blood through it, and it's just a good, reliable IV, not too big, so it doesn't occlude blood flow past the vein or past the device in the vein. And blue 22 is how I remember that. Green 18 is how I remember that. The others I don't really have a little memory aid for. Moving down to our medium IVs, these are a little bit longer. They're 1 3/4 as opposed to the 1 inch. We often will use ultrasound to place these. I like them because that longer catheter length, these are the same diameters as the corresponding colors of the short IVs, but the extra length gives that catheter more of a chance to get parallel with the vein, inside the vein, instead of being at an angle, say, kind of bumped up against the floor of the vein. It's able to get in there and get parallel, less likely to have a high concentration of medicine right there at the wall of the vein. We like that catheter, if possible, to be parallel. These two are both 18 gauge IVs. This one is a 2.5 inch as opposed to the 1 3/4. Next are the longer peripheral IVs. These are also called midlines, but they are peripheral IVs. They begin in the arm and they end in the arm. Usually you'll encounter these IVs in the upper arm. We'll use these sometimes to save a patient from getting a PIC line. We'll use those upper arm veins that often need the longer catheter to reach them and to then get parallel in the vein. This 22 gauge here is 8 centimeters in length, and then 10 and 10 centimeters for the 18, or the 20 and the 18. There we go. And for some reason we go from measuring in inches on these shorter lengths to centimeters on the midline, but so these are about 4.5 inches here. So 1 inch, 1 3/4, 4.5 inches here on the midlines. These midlines are power injectable, meaning that for people in the CT lab, if they're going to do a CAT scan and they want to use a power injection of contrast, they can read right on here that this particular midline can accept 7 mLs per second of a power injection. And it also tells them how long it is, 10 centimeters. That's for you nurses too, as you're getting ready to, say, take a line out. This tells you right on it how long it's going to be. And you can take these out as you would a peripheral IV. And it also will say power right on it, power glide, this one. But the word power tells the CT lab that it is in fact approved for use with their power injector. So before we look at our different central lines, I thought I'd explain what is it that makes a central line central. And really it's all about, really any IV line is all about dilution. We want the medicine that's going in to dilute quickly. And when we get to very stronger medications such as TPN, chemo, or some of the stronger antibiotics, these things are very irritating to the vein walls. As you may remember from your A and P, the inner lining of the vein is only 1 cell thick. And so it doesn't take too much of a caustic IV fluid to disrupt that 1 cell thick layer. And that's when the patient will feel pain. That's when things can begin eroding through the other layers of the vein and then get outside the vein into the body tissue around that area, and that's when we have the infiltration or extravasation. So the more we can dilute that, the TPN, the chemo, the antibiotic, the more we can dilute that, the better. And we want a central line to end in the distal 1/3 of this superior vena cava. Believe it or not, that is literally the size of a garden hose for a few centimeters there. All of the blood from the upper body is heading back to the heart. As it heads back to the heart, it all ends up in this one pipe for a few centimeters, and that's where we want that mixing to occur. That we want to deliver the chemo, the TPN, the antibiotics right here, so that very, very quickly it's diluted, and it will not then irritate the veins. So that's what makes a central line central. We've got to get it there, whether it's from a metaport, whether it's from an IJ, whether it's a subclavian line or out here a PIC line. They all go to the same place, this area, the distal 1/3 of the SVC. Looking over here, the most common central line that you're likely to encounter, the PIC lines. We place them here at Dartmouth on a pretty regular basis. I would say, something like 8 to 10 a day. And so a lot of patients on the floors may have these lines, and they can be either single lumen, double lumen, or triple lumen. And these are some different manufacturers, so they may look different, but they usually should say the word PICC, P-I-C-C. That stands for peripherally inserted central catheter. So it is a central line. PICCs are central lines. They just begin out in the arm, in the peripheral area. But they are definitely central lines. They go to the very same place that the IJs, metaports, and so on go to. I'm not sure if our photographer can zoom in here, but I'll try and show you. This is a triple lumen PICC line, and you see it just has the one tubing, but I'm going to hold this as still as I can. And you might be able to see that this one tube is divided 3 ways. And so it's divided in half, and then one of the halves is divided again into quarters. And for our purposes here at Dartmouth-Hitchcock, the half is the red lumen. So that's why we always want to do, if possible, blood draws through the red lumen. It's twice the size of these other 2 lumens. I hope that makes sense. So if you think of almost like a peace sign, the red lumen is the largest, and then you have these 2 smaller lumens. These are 19 gauge as opposed to the 18 gauge, the red lumen. Always, even when these are brand new, when you flush these lines, these other 2, the white lumen and the gray lumen, they'll always feel stiffer than this red lumen, and it's simply because they're smaller. The purple here means power, same as the purple hubs on the midlines. So this is a power PICC, and it will tell the people in CT. It'll say here no CT, and here no CT, and then here it will tell them it can handle 5 mLs per second for a power injection. That doesn't really concern you in terms of floor nursing. That's only for the people in the CT lab. But just wanted to explain what the lettering was all about. And we generally we set up our information in EDH to describe these by colors. Instead of distal and so on, we're using colors: white lumen, red lumen, gray lumen. And the reason we do that is our PICCs are cut. So we won't have staggered ports for delivery. We cut our picks straight across. We trim them to fit each patient, but so everything is delivered at the very same point. So there is no proximal or distal lumen. So we describe them by the colors of the hubs. Moving on, we've got the. Oh, I thought I'd show you. This is a pick that you might find in a baby or a neonate. This is a very small pick. It's amazing that they can produce a pick that small. But that's here's a typical. This blue line is a typical single lumen pick for an adult, and here's next to it is that pick line for a baby. And next we'll look at the metaports. And remember, these are going to the very same place the picks do. They're just, the beginning of them is this port that's just under the skin, usually around the clavicular area on the chest wall. And this is a single lumen, and this is a dual lumen metaport. Again, this is going to be under the skin, and they're accessed with a needle called a Huber needle. It's a right-angled needle. And so this silver part of the port would be under the skin, and this is a right-angled needle called a Huber. And once someone on the IV team or whoever will access this, they'll then put a dressing over it, and this is your access point on the floor. You can treat this more or less just like a PICC line. So you draw labs the same way. And again, this is a power port, and it will tell the people in the CT room how fast they can put the fluid in. And that's what this device is rated to. Hemodialysis lines are large. They need a lot of volume during dialysis to move in and out. And some of them, if we're lucky, and usually it's only the temporary HD lines, will have what we call a pigtail. This one does not have one. It's just the two HD lines. I can tell you we normally will not use these lines for blood draws. And if we do, we're very specific about needing an order from nephrology, and we want it to be very specific, telling us exactly what they want us, how many flushes we give, how much heparin, what concentration, and how much. These lines are very important to the patient, and they are the ownership. They're owned by nephrology, really, and we try and leave them alone unless absolutely necessary. And we would never draw labs from these without specific instruction from nephrology. With one exception, here's another HD line, but you'll see it has a third line here in the middle, a small line, and this is very much what you're used to seeing on the PICC lines. It's called a pigtail. And so these are the HD lines on the outside, the red and the blue, and we leave those alone. But if it has a pigtail, this is a very separate, these never come into contact with the other lines, and it's just there for IV access and blood draws, and it's really handy to have. Again, you can treat it just like you would a PICC line. One thing to show you is that there are staggered ports here. There's a port on the side and another port, and these are the HD ports. But on the very tip of this blue, on the blue tip, there's a hole, and that's the outlet for the pigtail. So it's completely separate from the HD line itself. So you can safely use a pigtail for blood draws, and that's actually what it's there for. It's there to be used, whether it's for infusing fluids or doing a blood draw. That's for you and us to use, not the main HD lines, though. I think that's pretty good. Okay, thank you. Hope some of that made sense. And when in doubt about any of your lines, if you're not sure what you have, please don't hesitate to call the Vascular Access Service. We'll be happy to come up, take a look, and figure out what we've got. Thank you.